and so forth. All right, guys. Like I said yesterday, we're just going to do kind of a quick expedited version of this chapter. This should mostly be repeat information. We went over a lot of this in the lifespan development. Okay, so anybody have questions about this chapter before we get started?
Chapter
34. Pediatric. Okay. All right, guys, what's a big thing to remember about communicating with peds?
Probably scared.
They're probably scared. Now, guys, if they're legit sick or legit injured, all right, yeah, they're going to be scared. One thing. What else do we need to keep in mind?
The parent,
What about the parent?
they're going to be involved too.
Hopefully, ideally, yeah, parent's going to be there. How does that change things for us? Okay, so yeah, guys, you can't go up to a 3-year-old and be like, hey, buddy, can you tell me who the president of the United States is? Can you tell me, how many quarters make $1? So we need to really rely on those caregivers, that parent, to say, hey, are they acting normally? Like, is this their normal behavior? Because if it's significant, we can pick up on some altered mental status, right? But we need to ask that caregiver, hey, is this normal for the patient? Hey, obviously you called us, but you're good with us treating and transporting or doing whatever we need to do. We need to get consent from that caregiver, right? What else?
They're probably gonna have the most information about like medical experiences.
Right. Again, you can't come up to my 3-year-old and be like, hey, bud, you got any allergies? Do you take any medications on a daily basis? He would actually tell you, yeah, I take my Vitacin gummy. That's what he calls it. His little chewable gummy. He gets that every day. But yeah, we're going to have to rely on the caregiver for any kind of sample history. What else? Communicating with kids in general.
I was gonna say, you could be where a parent's not there. I mean, you could be at a daycare, you could be.
Right. So we
somewhere
could be at a
school.
daycare. We could be at school. What do we need to keep in mind there when it comes to consent? So teachers can give consent. A representative, an authorized representative of that establishment, whether it's a daycare, whether it's a school, can give consent for treatment/transport. All right. What do we need to try to do first? Call parent. All right. Call legal guardian, whoever it might be. Try to get in touch with them directly. Guys, if you are having a situation where more commonly you report to a school, they get sent to the school nurse or they fall off the monkey bars at school or something like that. If you are trying to call the parent, you need to get that parent's first and last name and say, hey, I'm just confirming you're good. You're giving us consent to transport, blah, blah, blah. That needs to go in your chart. All right. Spoke to patient's mother, Susie Smith, over the phone, and they gave verbal consent for treatment/transport. All right, what else do we need to remember about that kind of situation if it's not an actual parent on scene? So that authorized representative can give consent for treatment/transport, but what do they have to do? Okay, they are taking temporary responsibility, temporary custody over that kid. If you report to a school, can't get parent on the phone, or even if we do get parent on the phone, hey, I'm not going to be able to be at the school for 45 minutes. I'll meet you at the hospital. Okay, great. That an authorized representative from that establishment has to come with you, has to chaperone that patient until they get to the hospital. Okay. So make sure that that's happening. If there's absolutely nobody else on scene, obviously you are taking temporary responsibility of that patient, and then the hospital assumes temporary custody responsibility of that patient until somebody else can get there. So don't just go pick up a kid from a school or a daycare and be like, hey, thanks for calling us, see you, bye. If parent's not going to meet us like immediately at the hospital, they're going to have to come and sit with the kid until they take care of that.
Yeah, there are cases where people won't do that.
Not usually. Typically, if it's a school, like they're aware of the rules and the kind of approach and policies when it comes to kids. Sometimes it's the principal, that comes with you. Sometimes it's a teacher. Doesn't matter who it is, they just have to be an authorized representative. Like you have to confirm that they actually work there at that establishment type thing. All right, what else about communicating with kids?
Get down to their level, talk quietly, calm.
All right, so get down to their physical level, right? Especially if they're hurt or not feeling well, they're gonna be what? Scared. All right, we have a uniform, we might look like a police officer, we might look like a scary bad guy, I don't know, just the uniform kind of puts the kids off. All right, we get out of a very loud, very bright truck. Okay, and we're walking up to them. We got all this clanky equipment. We got our stethoscope, our big jump bag, right? And then we're making a beeline towards these kids, and they're thinking, what are they thinking? Oh crap, I'm in trouble, or oh crap, they're gonna take me away, right? So try to be as less intimidating as possible. So physically get down to their level. We're gonna talk about the pediatric assessment triangle in a little bit. What else can you do to make these kids feel more at ease? Distract them. How? Maybe give them something to play with, keep them busy. Guys, my go-to, I might second guess this now in the COVID era, but I would pull up Netflix on my phone and let them watch cartoons, right? If they were super, super scared, be like, oh, hey, do you like, I don't know, Coco Melon? That's the kid, you probably don't know what that is. Or do you like SpongeBob? Or, do you like Paw Patrol? Okay, just pull up some YouTube videos or whatever so they can be like, oh, hey, you're cool. You're letting me watch videos. Cool. All right, guys, get them involved if you can. If they're not critically sick or injured, let them play with your stethoscope first so they see that it's not going to hurt them when you listen to lung sounds. All right, let them play with a minor piece of equipment while you're checking vital signs, or, hey, do you want to listen to your heartbeat? It's really cool. Let them listen to it, and then that can be happening while you're checking a pulse. Okay, so kind of distract them, get them involved if they're physically able to do so.
How common is it that the kids are put off by uniform? That's really sad to me, because my dad's a retired cop, my mom's a retired nurse.
It's not just the uniform, it's just the
It's like the authority figure.
not the authority, it's just the intense surroundings with the uniform, the equipment. They're already in a vulnerable situation. They don't know why we're there.
So in school today, they don't have fire department, first aid, police come to school anymore. I mean, that was.
I think they do in like elementary school, but yeah, I don't know.
It's Carl.
Of course, it's Carl, who's late.
We shall say, Carl.
Welcome, Carl. Welcome.
Where you been, man?
Yeah, so get them involved, tell them, try to convince them, hey, we're not here to hurt you. Hey, we're not going to be mean. We're not going to take you away from mommy or daddy, whatever that might be, just to get that rapport with the kids. Okay. What else do we need to keep in mind?
They don't have as broad of a vocabulary.
Okay, so we might need to become a little bit of a kid ourselves, right? We can goof around if they're stable, right? We might, instead of saying, okay, well, so what quadrant do you feel the pain in? Or does it radiate anywhere, right? Can you point to where your belly hurts? Probably not going to use a lot of medical terminology. Talk like Jay did when he was the 3-year-old who swallowed bleach. Okay, so just try to kind of water down the terminology and the approach and all of that stuff when it comes to pediatric patients. What else about the parents? Get them involved.
Calm, make sure they're calm too.
Do your best to calm the parents, okay? Because again, even to this day, my 3-year-old, especially my 1-year-old, if they're like, trotting around, my 3-year-old is just oblivious to walls. I don't know what it is. Like, he's lived in the same house his whole life, and he'll just be like running and just be like, bam, just like right to a wall. And then he'll kind of stop momentarily. And what does he do? Mom, is this okay? Should I laugh or should I freak out? Right? So they're going to look to that parent. If he looked at me and I'm like, oh my God, he's going to be like, oh, But if I'm sitting there and I'm laughing, I'm like, dude, there's a wall there. He's like, oh, it's fine. Mom's fine. I'm good. Okay, so if we can calm parent down, the kid picks up on parents' vibes. Sometimes that's easier said than done. All right, especially these first-time parents who think that like a stuffy or runny nose is like the end of the world. They'll be freaking out. If we can have an educational moment with that parent, kind of calm the worries, the vibes all around will be a little bit more calm.
How do you set a car seat to a stretcher?
What do you mean?
If you have to transport a baby,
Mhm.
how do you like? put it
You
in
literally
line?
attach it to the stretcher like you would a car. Like the buckles on the stretcher will go through the back loops of the car seat. You just click it in and tighten it. Okay. So try your best to calm parent, get parent involved, right? Because especially if a kid is not feeling well, they're not going to want to be taken away from mom or dad or caregiver. So if at all possible, we can keep that caregiver as close to that patient as we can. If the kid's freaking out about maybe some oxygen, have mom do it or have caregiver do it because that's less intimidating. They're not going to really trust you as much as they trust the parent, which should be the case, right? Should be the case. All right, so guys, again, a quick recap of the different kind of groups of the ages in pediatrics. What's an infant classified as? What age?
0 to 12 months.
1 month to year.
1 month to 12 month, right? What's under that? What's from birth to 1 month is neonates. All right, so infant is 1 month to 12 months. Guys, what happens here? Like in this first 11 months of life? First second, I don't know how you describe that. What's happening?
Lots of growth.
Lots of growth, all right, physically, intellectually.
They move from being totally immobile to mobile.
All right, so they typically move from, hey, if I put you there, you're gonna stay there, to, hey, I have to go like chase after you and follow you everywhere you go, because they start to become mobile, like walking and crawling. Especially under like 6-9 months, what's their only way of communicating? Crying. Because they cry when they're hungry, when they need a diaper change, when they're mad, when they're scared, when they're cold, when they're hot. All right, what's really important to understand about this?
You have different cries for different causes.
What'd you say?
That's a nominative.
Right, guys, there's different cries. Okay, I can tell you, even my 3-year-old still, but with my youngest, when he starts fussing, I know, oh, he's tired. Oh, he's pissed. Oh, he's hurt. Brother probably hit him. You know, so the responsible caregivers can pick up on the different nuances of the cries, if there's a sense of urgency in that cry. So if you don't have kids, you can't probably fully understand that. But if mom says, I don't know what this cry means, I've never heard this cry before, or this is a hurt cry, something's wrong, you need to listen to that parent because it's a legit thing. Okay. They sleep a lot. They can't communicate like verbally, right? So just understand that this is going to be a harder assessment to try to figure out, if we can, what's going on, like pinpoint, an injury site or a pain site, because they're not going to be like, oh, that hurts, or oh yeah, hey, right here, check this out, type thing. Okay. Especially the younger infants, again, that hypothermia. Remember yesterday we talked about delivering the baby. As soon as we get them out, we warm, stimulate, dry, and we crank that heat up. They are not able to thermoregulate well until usually 9-ish months. That's why you see these babies even sometimes in the summer, like newborn babies are in long sleeves and pants because they literally can't thermoregulate. Okay. What do we need to keep in mind about these pediatric milestones? What is a milestone? What does that mean?
It's where things like typically should be, but it doesn't mean that they'll always get it on time.
Okay, so for example, around that 2 to 3 month mark, they should be doing what with their eyes? Be able to track. All right, so that means if somebody comes up to their kind of area of vision, they should be able to say, oh, hey, I see you. If they're fixated on you, if you move to the left, they should be able to follow you. Okay, usually around 6 months, They should be sitting up by themselves. Usually around 9 months, they start crawling. Usually around a year, they start pulling up / walking. Guys, be familiar with these milestones, these physical and mental milestones, but keep in mind what? It's not a dead set. If they are not crawling by 9 months, there's something wrong with them, type thing. All right. Now, if we're significantly past these milestones, if I have a 2-year-old who can't crawl, all right, or can't be mobile, yeah, I'm concerned. All right, but just remember, sometimes we use these milestone marks as a point of trying to understand, do I have altered mental status, right? So if I have a 9-month-old kid who is not tracking me as I walk in, who is not able to follow anything with their eyes, I might be concerned that we have maybe a cognitive delay or a physical delay, but then I also might be concerned that, hey, my patient could be sick and have altered mental status if we're not tracking and following at this, late of an age, okay? Guys, what do infants do to explore? Everything they see that they can pick up, well, even some things that are stationary, go in their mouth, right? What are some things to be concerned with here? All right, so what's true about airways in kids? Much smaller, okay? So these Legos, these beads, these coins, that's a big one, batteries, all of that stuff. They test everything out, goes in their mouth, especially if they're teething, right? They like to grab objects and kind of gnaw on it because their gums are very uncomfortable. So we worry a lot about foreign body obstructions. All right, typically, once we reach this toddler stage, for the most part, they're somewhat mobile. All right, crawling, standing up, kind of pulling up, kind of like walking with some support, or just totally walking all together. They also are very curious. All right, so this being mobile and being curious can lead to what types of issues? Hurting themselves, right? Because they don't really have the understanding of, hey, this is a flight of stairs. Probably shouldn't go teeter-tottering down the stairs because I'm going to fall a long way and hit my head and get badly injured. They don't have that concept. They don't have that grasp of like depth perception, cause and effect. All right, so we see an increase in trauma, particularly drowning, especially during the summer. If there's not like a fence or secure thing around the pool, they don't understand what water really is or how deep it is. They don't know they can't swim type thing. What else? What else, Jay? Ingestion, right? Typically, probably, obviously, accidental ingestion, household chemicals, parents' medications, prescriptions or over the counter, like anything around the house that's not meant to be ingested at this point. If they're walking around or crawling around and exploring and anything's on their level that they can reach, not good. Okay, so keep that in mind. At this age, guys, typically from starting around 6 months, they start to eat like that pureed baby food. Usually around the 9 to 12 month mark, when they start to get some little chompers, they can eat like soft or very small human food, table food. Okay, so again, the more table food they're eating, bigger risk of aspiration. So keep that in mind. Three to six, preschool. Typically by this age, a big milestone is going to be what? Talking. Oh yeah. For most, for kiddos. Yeah, my 3.5-year-old will have conversations with me. I'm like, how do you know what that word means? Or where have you how do you know these things? Right? What else? Potty training. All right. typically around that age of 3, for the most part, you see most kids are potty trained at this point. Guys, it might be, closer to 4 if they're potty trained. But if we have like a 6-year-old who is still in diapers, we need to be considering that this is probably a little beyond normal. We might have some type of physical or mental delay, or possibly maybe not necessarily abuse, but neglect, right? These kids, if they're not being taught or spent time with at home just to understand that we're growing up to be a big boy, we don't need to go to the bathroom in a diaper anymore, they're going to be none the wiser, right? So start thinking about things like that. They're a little easier to communicate with, right? We can give them like a direct question. Hey, can you point with this finger where it hurts? Or, what feels bad? They can typically, these very direct, short instructions, they can typically follow that at this age, especially up to the 6-year mark. Guys, what's true in all age ranges, but especially when they get to the point where they understand like cause and effect, or trust is really starting to become a thing with them. We don't need to what to these patients? Lie to them, particularly in what regard? Pain. Right? You're not going to be so much concerned about starting an IV or anything like that on a kid. That would hurt them. What's going to be your main source of pain? Glucose. Right? Because we got to remember that type 1 diabetes is juvenile onset. So if we're having a confirmed background of diabetes, or we're concerned that this could be a new onset and we need to check a sugar, we don't need to say, oh, it's okay, this isn't going to hurt, right? Because the second that kid feels that pain, I'm like, oh, lie to me, all right? That communication's done with, all right? You're going to piss them off. If you need to do anything else in the future, they're not going to let you because you don't tell the truth, right? So just make sure we're not lying to these patients. How can we kind of preface that if we do have to do something that's not going to be pleasant? So it's to help you, but let's say you're checking a glucose on a kid.
You say you're going to feel a little pinch and it's going to go away.
Yeah, so just be like, it's just going to be a little sick and it's going to be over with. You're such a big, brave boy, girl, you can do this type thing. Just kind of downplay it a little bit, but do say, yeah, it's going to feel like a little sick, but then it won't hurt. All right. School age 6 to 12, we start to become a little more mature, start mimicking like daily activities that, adults do, start to begin to understand the finality of death, but not truly. Hopefully you guys won't have to have that kind of conversation, but especially at this age, try to get the kid involved. All right, say, well, hey, I have to do this. Like especially if they're not like being cooperative or they're not like talking, like, well, I need to do this or this. Which one do you want me to do first? Or, not like allow them to omit any part of that needs to be done, but give them some like control of how the assessment's going to go so they feel a little bit more comfortable type thing. Again, involve them in their care. Guys, if they have, a comfort item, a toy, a blanket, something like that, what do we need to do with that? Bring it. Right now, if it's like a dog, like a literal dog, or live animal, obviously, we have some hurdles there. But yeah, just incorporate anything you can to make this kid feel more at ease. Adolescents, these mofos. All right, what's going on in adolescence?
All kinds of things.
All sorts of things. All the things, all right? Most prevalent, puberty, right? What comes along with puberty?
Stupid decisions.
Stupid decisions, hormones, different urges that are going to be acted upon, curiosity about fitting in at school, peer pressure with drugs and alcohol and all sorts of stuff. All right, we see a very sharp jump in the amount of trauma cases, right? Because what goes through the mind of a teenager, especially like high school?
I
I am Superman. Nothing can touch me. I'm in the prime of my life. I'm the all-star jock, or I'm whatever. I'm not gonna get sick. I'm not gonna get hurt. I got this. Hey, let me chug this bottle of vodka to impress this girl or whatever. Okay, so we see increase in trauma, especially seatbelt use.
Seatbelts, what are those?
Yeah. Yeah, I think I told you about this guy I went to high school with. He would actually, instead of, because if you don't buckle up, it like yells at you.
Yeah.
He would go to the extent of buckling in the seatbelt and then like pulling the shoulder belt and like sitting on top of it. Okay.
You want to hear something funny? So you're talking about how like important like the headrest is. This kid I knew in high school took it off so he could wear his hat backwards when he was driving.
Oh, was his name Chad?
Close enough. Jake.
Okay. So yeah, understand this, guys. You're gonna need to be a lot more aware of modesty with the adolescents, right? They're gonna be a lot more kind of conscious about body image at this point, and honestly, this day and age, it starts earlier and earlier. So probably pre-pubescent, these kids might be concerned about body image. They might be concerned about, hey, like, I don't want anyone to see me in a vulnerable state. So privacy is going to be a really big thing at this age. Keep that in mind. Teen pregnancy is always a thing that we need to be conscious of. Remember, we talked about it yesterday. This might be something it's not as prevalent, but it's still kind of got kind of a stigma or taboo. They might not want their parents to know. They might not want friends to know. So just keep, again, privacy in consideration when it comes to more so this age group. Because they are still what? Minors, all right? Unless they are emancipated in some way, shape, or form, they still are under the care and decision-making capacity of who? Parents, all right? You might get helicopter parents who want to be right there and hear everything that patient's saying, hear all of this information, and legally they're allowed to do that, right? So what are some things we might need to take into consideration about this particular age group and their privacy?
They might not feel comfortable talking about something.
Yeah. All right, especially if it's anything that relates to sexual activity. Could possibly be an STD, could possibly be a teen pregnancy, anything like that. Maybe something happened, they were out, they snuck out, and they did something they weren't supposed to while in this event happened. So how can we try to get the most honest feedback from our patients? Yeah, divide and conquer, distract parents, say, hey, between you and your partner, I'll go talk to the kid, you go handle the parent. All right, kind of tag team that. We can kind of get the kid in the back of the truck, get some privacy and say, hey, if it's something that you don't want your mom or dad to know, that's fine. I won't tell them, but you need to be honest with me while my partner is talking to the parent about maybe some medical history, or hey, can you go run and grab their insurance card? Can you go run and grab this? You can try to distract that parent so we're not just like inadvertently saying, hey, they don't want to talk around you, so you need to leave. Because what's that going to do to the parent? Well, what do they want to talk about? I need to know more now, right? So just try to distract the parent, give them a task, or try to divide and conquer with your partner if you're sensing that this is something like your patient's not being forthcoming because they don't want to talk around friends, parents, whoever that might be. All right, guys, again, we've already kind of touched on this. The biggest difference in anatomy that we need to be concerned with is going to be that kiddo's airway, right? I think I told you guys earlier, when they're born, it's about the diameter, the trachea is about the diameter of a drinking straw. It obviously gets bigger and wider the bigger that they get, but aspiration is a very, very major concern, okay? Kids are what driven? Respiratory driven, right? If we have a kid that is looking pale, cool, clammy, cyanotic, anything like that, you need to be extremely aggressive with managing that airway. And guys, I don't mean it in the sense of what? Like, don't be like just bagging the shit out of that kid, right? Because we can do what? We can pop a lung. All right, but that needs to be you zone on and getting those ABCs taken care of. Let's get high flow O2. Let's bag this kid. That needs to be your first priority after scene safety, after life threats, all that stuff. Okay. What else is disproportionately large? Their head, absolutely, and their tongue. Okay, so small trachea, big head, big tongue, not a great combo for airway obstruction and aspiration. Okay, so remember, if we're trying to manually open the airway, especially of an infant, what's something we need to be doing? Placing them in what? Back to CPR day.
Oh, sniffing.
Sniffing position, right? If we lay them flat, it's the equivalent of like an adult patient having a motorcycle helmet on their head. Their head's going to be jutted forward, so we want to get a shirt, a towel, a sheet, place it in between their shoulder blades to kind of lift up and create that little void space so that airway can totally go into alignment. All right, don't forget that. So again, guys, especially in this infant stage, if we have a respiratory call and we get on scene and we're doing our assessment, we're doing that PAT, we'll talk about that in a minute, and we're like, ugh, this kid is legit. It's not just a runny nose, like we're having some difficulty breathing. All right, what's something we want to keep in mind there? How do we want to interact with that kid? Especially if it's an upper airway issue. We don't want to do what to these kids?
Make them cry.
Piss them off, right? Because if they get pissed off or if they get scared, what do they start doing? Yelling and crying and fussing, right? If it's an upper airway issue, all of that extra strain, especially around the vocal cords, all of that is going to further irritate that tissue, that area, and we can exacerbate, we can expedite the swelling of that airway to the point where we might lose that airway. So try to keep these kids calm. Probably keep them being held by who? Caregiver, okay? Probably have caregiver give that blow-by oxygen or that humidified oxygen or whatever we decide to treat with, so they don't fuss and scream and further irritate that upper airway. Infants are obligatory what breathers? Nose breathers, all right? So what is something that we need to look for that could indicate difficulty breathing with them? Nasal flaring. All right, it takes a little bit for these kids' brain to say, I'm having difficulty breathing. Maybe I should open my mouth and breathe. All right, so if we see that nasal flaring where it's almost like accessory muscle use of the nose, right? That's a big sign of difficulty breathing in these infants. Guys, you're going to need to go back and look at your vital sign ranges again, right? What is globally true about pediatric vital signs? Okay,
It can be a little higher.
everything is elevated with exception of blood pressure. Okay, so make sure you're aware. If I come up to, if y'all came up to my 3-year-old and noticed that he was breathing, 26, 30 times a minute, would you be concerned? Should you be concerned? No, that's normal for them. If I come up to an adult patient, they're breathing 30 times a minute. Okay, we got to work with some things here. All right, so especially with that heart rate and that respiratory rate, guys, you got to understand what that normal range is. So if you do an assessment and you're like, oh man, that's tachycardic, is that normal for that age group, or are we in still bad tachycardic range? Okay, so make sure you go back and understand those. The older they get, the less we see this, but the younger they are, we usually can count respiratory rate from what? Visually.
Watching the bellies rise.
Belly. All right, they're belly breathers. If you notice, if you have a younger kid, you know, in your life in any capacity, if they're sitting there chilling, watch their chest. Their chest rise is very, very, very minute, but you can actually see they use more so their abdominal muscles to help them breathe. All right, those chest wall muscles, those pectoral muscles, that diaphragm, it's not nice and strong like it is in an adult. So they're typically belly breathers versus, I guess, chest breathers. But you can get a better visual of a respiratory rate from their belly rise than you can their chest rise. Talking on the vital signs, guys, what's true about blood pressure in peds? Okay, so it's lower. Everybody know why it's lower? Less surface area, right? They got less pipes to pump to, so it's not going to have to work as hard. Okay. What's true about obtaining this stuff, the blood pressure on kids?
They different size, so you have to use a pediatric cuff.
Definitely use a pediatric cuff for sure. But guys, unless they're critical, we typically will omit a blood pressure for kids like 4 and under. Okay, it's very hard to hear. It's very faint. Kids typically won't cooperate. They don't like that pressure sensation. All right. So what's a cheat formula you can use if you can't remember the exact blood pressure ranges?
So 70 plus 2 times their age.
So it's 90.
90 plus 2 times.
Okay. If you take a blood pressure and you're like, well, crap, I don't know if this is a normal number. Okay. You can look just at that systolic number and have this little cheat formula in your head. The average systolic should be 90 plus twice the child's age. All right, so if you've got a 2-year-old, what should the average, like that 50 percentile for the systolic blood pressure be? 94. All right, 90 plus 2 times 2 is 4. Now guys, what's gonna fluctuate with that? We say that's average, that's that midway range. Okay, so maybe what's going on,
The
but
size of the child.
the size of the kid, right? If you got a teeny tiny kid, a teeny tiny 2-year-old, or you know, a massive crazy fat 2-year-old, like with my 1-year-old right now, there's no way he's in that mid range, right? He's massive, guys. He wears a size 3T, and he is like 2 pounds away from his 3-year-old brother. He's a beast. All right, so his systolic is probably going to be a little bit higher than 92. All right, just because he's the big one. All right, so just use that as your reference. If you get a 4-year-old and you get a systolic of 100, okay, is that around what it probably should be? Yeah. All right, so 90 plus twice their age, and that's just systolic. You're not going to get a diastolic range with that. So again, going back, recap and pulse, it's going to be higher. The older they get towards that adolescent range, they start kind of normalizing to the average 60 to 100 heart rate, 120 over 80, 12 to 20 respiration, all that jazz. Guys, we talked about pediatrics are respiratory driven, they're oxygen driven. All right, so be really aggressive with that. Why do we see not as many spinal cord injuries or like true through and through breaks with kiddos? A little flexible, right? They're a little bit more pliable. When we start to get around that school age group, we start to have more of that, you know, solid structure to the bone, especially in the adolescence. But yeah, they're a little flexible, they're a little pliable. So We see less like absolute, very obvious fractures. But we're gonna treat them all the same, right? We talked about that epiphyseal fracture when we talked about orthopedics. If we have an injury or a fracture to that growth plate in a bone, in a joint, we can have long-term concern about that. It might stunt the growth of that particular limb, but are we really concerned with that with our interaction, our time frame for the kid? Not really. Everybody good on fontanelles? Talked about those yesterday. What are those? Soft spots, little squishy spots. Why do we have those? Why is the skull not fully fused when we're born? So it can literally change shape to fit through the birth canal. Okay, guys, typically by a year and a half, these fontanelles are totally gone. The bones, the plates are totally fused together. So at any point you've got a patient under that age of, a year and a half, be very mindful when we're handling or assessing the head, because what can happen? If you poke through that soft spot, what are we going to be coming in contact with? Brain. Not good. So again, why we assess, another reason why we assess with flat hands. What can fontanelles tell us? If they're dehydrated, what might we see? Sunken in fontanelles, right? If you feel a normal, healthy infant's head, you're going to feel a little bit of squish just because those plates are not fully fused together yet. So that's normal. If you're petting, you could probably feel like a little dip. But if you are assessing that fontanelle and it's significantly noticeably sunken in, like the skin itself is being pulled down, bad sign of dehydration. Okay, very late sign, very bad sign of dehydration. Those fluids are nowhere near where they need to be. And what else can we tell from fontanelles? If they're bulging, if you're assessing a fontanelle and it goes up like a little hill or a little knot, what's that going to tell me? We got a lot of pressure, ICP going on. Okay, so don't forget your fontanelles when it comes to assessment, because they can tell us a lot, especially if we have an altered or unconscious infant that can't tell us anything. Those are some really valuable assessment points. All right, so our pediatric assessment triangle. What is this? What is it made up of? How do we use it? When do we use it? For our assessment, definitely. All right, guys, we are going to look at all of these three components that make up the pediatric assessment triangle. We're going to do this entire assessment before we even touch my patient. All right, as we get off of the truck, the second I have a visual contact of that pediatric patient, that PAT starts. All right, as I'm walking up to the patient, before I even place my hands on them, I'm looking at these three things and I'm gauging in my mind what? Sick or not sick, right? For the most part, critical or stable. All right, this should be done in around 30 seconds, like not even that. Okay, what's your three components? Appearance, work of breathing, circulation. All right, appearance, what am I looking for? Okay, so are they conscious? How can I tell that? Okay, so maybe are we at an age group where they should be tracking me? All right, I can use what for this? AVPU. All right, what about determining a GCS? Because we know we can use AVPU as an initial, a little bit more vague tool for level of consciousness, but how do I know if they're altered in any way, shape, or form? Okay, so their response. Can I use a GCS for a 9-month-old?
No.
No. Why? They can't talk. right? They can't effectively verbally communicate. They can't understand half the words that are coming out of my mouth. You see rush hour? Okay. All right, so we need to have a modified version, like a pediatric version, if you will. There's not an official one, but what do we need to try to gauge this by? What's normal for their age. So again, we need to be very familiar with those different milestones, okay? But also what? Who am I gonna really use for this?
You're gonna use the parents.
Right? Are they acting normally? Are they always this tired? Do they always do this, or is this different? Again, guys, if they're attentive, if they're a responsible caregiver, they will be able to tell you what that kid's baseline is. Okay?
Trick says to tell you he's on his way, and he says to tell you his car died on the way.
Okay.
So that's-
Who?
Fred is on the way, and Andy's car died. Andy?
I can't wait for him to do a clinical because he's gonna be like the biggest shitbag. Like everything always happens to him.
It's a badge buddy I got.
That was a great
That's
story.
like a pediatric GPS one.
Yes, guys, you need to get a pediatric badge buddy. Okay, get that one we talked about in age or lifespan development that tells you the vital sign ranges, and then also tells you like those milestones, how to properly further assess pediatrics. Okay, because when it comes to this, we get some pediatric calls, but we get very few critical pediatric calls. All right, so even, medics who have been on the street 10 years, when they run a pediatric cardiac arrest or they've got a sick kid, they're brushing up on their stuff before they get on scene because we don't commonly come in contact with critical pediatric patients. Knock on wood, whatever I need to do to make that not come to fruition. Okay? So absolutely no shame in pediatric badge buddy. I encourage it. I have one. All right, work of breathing. What am I looking at here?
Accessory muscle use,
Accessory muscle use.
routine, Strider.
Okay, so if I hear anything audible, like stridor, what else? Nasal flaring. Okay, if they're to the point where they can be in a tripod position, right? Like physically able to do that. Head bobbing is another, that's kind of their tripod position, right? Because you're not gonna see a 9-month-old doing this, right? Like taking a breather. But if they're getting to the point where they're becoming altered, they're becoming hypoxic, you'll see like the inability to like kind of keep their head upright. Okay, so that's another big indicator we're not in good territory. Circulation, what am I looking for here?
Good color of the skin.
Color of the skin. All right, is it warm pink? Or well, is it pink? Is it blue? Is it mottled? Is it pale? All right, keep in mind kids are normally what? Paler, on the paler side if they're light skinned. They're not gonna have like an immaculate tan, right? But just look at the color and the presentation of their skin. If we have a purple or a blue color or a pale or a gray, anything like that, that is not that standard pink, that's telling me that I've got good perfusion. We're not in great territory again, okay? All right, so again, guys, these 3 things, you can assess these 3 things without putting hands on your patient, okay? Do this before you get to physically touch your patient, do it very quickly, and that right off the bat should raise red flags and be like, crap, we need to literally grab this kid and go, or we're good, we can stay out, we can hang a little bit, okay, because this PAT is going to tell you sick or not sick. All right, guys, all of that, keep the caregiver involved, bring a blankie or a toy or anything like that. That's for what kind of pediatric patients? Stable. Okay, if we have a very poor PAT finding, literally what are we going to be doing? Like if they're not already in cardiac arrest, we're literally going to be doing what? Take the kid, turn around, and go to the truck. We do not waste any time when it comes to transporting and treating these kids. Okay, so just keep that in mind. It's very, very expedited if we spend any time on scene, if that kid, because guys, most of the time, if the kid is that bad off, where's the caregiver gonna be? On the porch and, you know, on the side of the road, like waiting for you to get there. Okay, so very, very quick turnaround time with these kids. And the first thing we need to do is what? Get that BBM out. Okay.
So I appreciate what you're saying about immediacy, but you don't mean, you're not implying that there shouldn't be a little conversation or says, hey, look, we need to move.
Walk and talk. Let's
Yeah, I'm
go.
gonna say.
Let's walk and talk.
Mhm. And guys, if that kid is legitimately that bad off, the parent is going to be, they're going to follow everything that you say, and they're going to have that sense of urgency as well.
At the same point, if you just would have grabbed them away.
Yeah, no, don't just be like, okay, I'm like taking your baby and not like say anything to the parent. All right, if we have a very poor PAT, be like, okay, let me take her from you. All right, come with me, talk to me, tell me what's going on. And you'll get that parent in the back of the truck with you, and you're gonna be literally working while simultaneously getting that sample information, OBQR, well, not really OBQRST, but, okay. Everybody good on the basics of managing airway for peds? Sniffing position, have what ready? BVM, yeah.
Have the BBM.
Suction. Okay.
Since pediatrics has a generally elevated baseline body, which would include things like respiratory rate, is there like a textbook correct BVM rate for pediatrics?
So
Or is this kind of
neonates is, it's
3 to
every
5
3 to 5 seconds through infancy. So you're gonna bag every 3-4 seconds. Guys, if we're getting to the point where they're starting to Brady down, not good. Remember your magic number when it comes to heart rate and CPR? 60. Okay, if you've got an infant that has a heart rate of 60 or less and is showing crappy signs of perfusion, you're going to start your ratio for CPR. Okay, everybody go with that? Don't forget, just with adult patients, check those pupils. Don't forget to check a sugar. All right, those are some very telling signs that a lot of people just kind of forget about or forget to assess or just don't think about it. All right. Again, guys, if they're cold, warm them up significantly. If they're hot, cool them significantly, because their ability to regulate that internal body temperature is not mastered yet. So we need to, if it's any environmental exposure, we need to be aggressive with treating with the opposite of what they've been exposed to. ALS is always, always, always a good idea for kids. Okay. I know we say get ALS en route for any patient. We can cancel if needed. But if it's a pediatric and we establish that they really are critical or sick or injured significantly, ALS can more effectively, more aggressively manage that airway. So just keep that in mind. So yeah, transporting these patients. So we were talking earlier, guys, if it is an infant that is still in one of those big, like legit car seats, all right, typically under the 40-pound mark, we're going to transport and they're stable, right? Obviously, if these kids are critical, am I worried about bringing a car seat with me?
No.
Because where are they going to be when I'm treating them? Laying supine on the stretcher, all right? But if they're stable, we can transport them, have them buckled effectively in the car seat, and then we're going to strap the car seat onto the stretcher. All right, so you'll sit the head of the stretcher up at a 90-degree angle. There's these little slots in the back of the car seat that typically an actual car seat belt will go through. You'll just use the stretcher seat belts to secure the car seat to the stretcher. All right, we have things, if they are a little bit bigger than that, they can't really fit like in maybe they're the size to fit in a booster seat. We have this thing called a PD mate. I think we've ordered some to show you guys, for example, but they're not here yet. It's like an attachment that you put onto the stretcher, and it's a modified version of the stretcher straps.
Well, I handed it to me since it was on the stretcher.
It's not that confusing if you've handled
If
it
you've done it
before,
before.
or if you're around like car seats on a regular basis. If you're not, it just looks like a bunch of different spider legs. You're like, what do I do with this? Okay. It's almost like if you see, you know, the parents walking around with like the little attachment thing, and they just like put the kid in the carrier and they walk around, and their legs are like, you know, dangling down. It's kind of like that for a stretcher. Okay. In the captain's seat, there is a little part of the seat itself that pops out. So that becomes a modified booster seat. We can put kids on there. So yeah, just be familiar with what your truck has, what equipment you have, but there are different modifications for transporting these patients safely. Guys, we talked about managing history taking with the caregiver. If the age is not to the point where they can effectively communicate, making sure if they can effectively communicate, we're trying to separate as much as possible if we're picking up the patient's not being honest. Again, with the kiddos, the infants, like for especially with dehydration, some questions we can ask to figure out just how dehydrated they are. How many diapers have you changed, right? Like with my son, I can tell you my 1-year-old, like, an approximate amount of diapers, like pee and poop. That's average on a daily basis for him. Okay, if I'm only changing like 2 pee diapers throughout the day, hold on, let's go get you some juice. You're not having enough fluids. Okay, so that's a really good indication. Don't forget, especially in these infants, if they're having, you know, altered mental status, anything like that, we probably want to strip them down to a diaper to see if they do have any rashes. What are some things that can be bad for kids that present with a rash? Meningitis. Okay. A bunch of different viral things can present with a rash. So if they're bundled up, or if they have, you know, like a onesie, or they have clothes on, if they're altered, if they have these other, you know, kind of not great signs and symptoms, let's check out and see if there's a rash present. Usually it's going to be on the core. Okay.
Meningitis will present the rash.
What do we want to do about physically assessing your patient? If we're to that point, if it's going to be a thing that we need to do, where do we need to start doing this? Start at the feet. Take a little piggies, right? You know, say, haha, I'm not going to hurt you, like I'm playing with you, and then work your way up to the head. If the patient's stable, right? Because if we just go straight for the face, these kids are going to be like, nope, I don't like you, get out of my space, stranger danger, and won't cooperate for the rest of the assessment. So start at the feet and then work your way up. Guys, most of the time, especially during flu season and germ season, right? Most of the calls we're going to get for kids are for a stuffy nose. All right. Most of the time we get on scene and, oh yeah, they got a runny nose, they're coughing, all this stuff. They don't have a fever, and mom wants them to go to the emergency room. Okay. So that's going to be the majority of the pediatric calls that you run, especially during the colder months. We always want to have that, you know, fall back safety net. We always recommend that you go to the hospital because there's some things that we can't do on the truck that they can do there. Because if it's like flu and cold season and the kid's not altered, their pulse ox is fine, you know, they don't have a fever, we try to have an educational moment with these parents. Say, hey, if it's a cold, it's literally a virus. There's nothing that they're going to be able to do for them. They might go to the emergency room and be around all these sick kids and leave with something else that they didn't have before they went, type thing. But just anticipate a lot of runny nose calls during the colder months for these parents who freak out because they don't know any better, or they're just like, whatever, we can go to the ER. Okay. Guys, you're going to assess for the same things in the same body systems. We're going to assess for it the same way. But obviously you might not apply as much pressure for GERD Keep in mind the difference in the anatomical sizes of things, but the assessment from head to toe is gonna be the same on a pediatric patient. Hello, sir.
Good morning.
What you? Like a thing, a pull thing? I think I'd zip them and put them in my office on the filing cabinet. Okay, so from 1 to 10, excuse me, it is 70 plus 2 times the age. But when we reach that 10 up to the 18, then you can kind of preface it with a 90. My bad. Pupils should be the same size. You're going to use the same pupillary measurement scale when you're assessing pediatrics. Q5, Q15, stable, unstable. That's going to be the same with pediatrics. Guys, what do we need to keep in mind though about the transportation of these patients? Huh? So yeah, if we're to the point where we're transporting lights and sirens, they're probably going to be altered, right? But where do we need to take these kids? Pediatric facility. Okay, so whatever area you get a job in, you need to be very well versed as to the closest pediatric facilities, especially the pediatric trauma facilities. Why are we concerned with getting them to that specific location? Huh?
They have the right sizes.
Yeah, the equipment, guys, they have the itty bitty baby size equipment. Okay, they have more specialty equipment. They have more staff that does kids day in and day out. Grady is a great trauma center, but are they gonna have an itty bitty pediatric C-collar or, you know, different splint sizes? Yeah, they're gonna be more so geared towards adults.
Kind of speaking of, one of the slides a little ways back said, you mentioned if they have a bad hemorrhage, they'll use a tourniquet. What's the minimum age that like a standard tourniquet's going to work on?
It depends on the size of the kid, but yeah,
I mean,
these,
speaking typically, we're talking like a 5-year-old, a 10-year-old, 2 months.
five, no.
Yeah, it's not, I know it's not. gonna
Five's
be-
pushing it. But yeah, I mean, probably average like 7-year-old. That's why I talked to you guys about those SWAT T tourniquets. Those are becoming more and more popular because they're a very good option for pediatric tourniquets. Grady doesn't currently have them, but they're trying to, more EMS services are trying to get more all-inclusive equipment that's geared towards peds. So yeah, they're not gonna work on teeny tiny kids.
Yeah.
But yeah, take them to a pediatric facility. Guys, if there's loopholes at every service, but here at Grady, for the most part, you're going to transport them to the closest appropriate facility, right? I was doing, I think it was a paramedic clinical at Grady. And there was a crew that came from another service that was way south of Atlanta. All right. They were coming from the south, 75 south, coming 75 north. And the closest trauma center that they were going to pass was going to be Grady. It was for a 3-year-old patient. Okay. Now this patient was critical. This patient was bad off. Did it make sense for them to bypass Grady and drive another 15, 20 minutes up to 285, up to 400, all that stuff to get to Eggleston? No. So there are some ways that there are loopholes. So that crew, they radioed in Grady and they let them know, hey, I know you guys aren't peds, but we got a critical trauma patient. We're going to be coming to you guys instead of, spending that extra 15 minutes on the road type thing. Okay. So just keep that in mind, but that'll vary from service to service or territory to territory.
Is Grady the first burn unit for peds?
Absolutely.
A 3-year-old burn.
It does not matter if the kid is 6 months old or 6 years old or 16 years old. Grady accepts all age groups for burns. So yeah, if it's a specific burn center, they will accept pediatric patients. That's where you can take a pediatric burn patient. Again, all this stuff goes straight in their mouth. Everybody good with epiglottitis? What is it? Swelling of the epiglottis. What are some common presentations of it?
I'm sorry, my connection was kind of bad. Professor A, can you say that one more time?
Just going back over epiglottitis, what it is, how it presents. So the epiglottis is swollen. It hurts to swallow. It hurts to move that flap around. So they're present with a lot of drooling because they don't want to inflict that pain when they swallow that extra saliva of moving the epiglottis around. Low-grade fever, stridor. Don't piss those kids off. All right, so remember again with lung sounds, it's going to be the same landmarks, mid-clavicular, mid-axillary, because their lungs are a lot smaller, right? Their rib cage is a lot smaller. So make sure that we're not going down, way far, like we have that muscle memory on an adult. Everything's going to be smaller. It's going to be more compact when we listen to lung sounds. All right, remember the baby pancake? If we've got a choking infant patient, right? 5 back blows, 5 compressions. We don't do what to try to get it out? A blind finger sweep. If we can physically see the object, we can try to extract it, but we're not going to go just kind of fishing around and see if we feel anything, because we can possibly do what? Push it in further.
More damage.
Mm-hmm. If they're big enough, we can perform the Heimlich. Okay. Guys, asthma is common in children. A lot of times they grow out of it. How do we treat it? Same way with an adult patient, right? Lung sounds will present the same. If they have an MDI, we'll use that the same. Pneumonia, why is this common in kiddos?
It's a form of a respiratory issue.
So it's respiratory, right? But why?
Secondary to getting colds and leaving a lot of colds.
So it's usually secondary from having just a common cold. But how does pneumonia develop?
Just goes from cold, just goes further down the airway to the lungs.
Okay, so all of that gunk actually goes further, it migrates further down into the airway and settles in those alveolar sacs. But why do you see more kids with it than adults?
Less distance to travel.
Less distance to travel. Also what? Anyone here ever had pneumonia? Okay, what do you constantly do when you have it? You're coughing up all that crap in your lungs, right? We talked about kids, their muscles are not as strong, they're not as developed, so it's harder for them to expel all of that gunk in their lungs. So it'll sit there, it'll fester. It's a respiratory problem. It's just a big snowball. It can be very fatal for kids. What's croup? Bad. But what does it affect? That upper airway. What's the telltale sign of croup? That seal bark cough. Bronchitis, bronchiolitis, guys, just depending on the anatomy, that gets irritated, gets affected by this. This might be chronic. They might have an MDI for this, or it could be an acute thing. Keep the kid calm. We have a Hawkeye for that airway. Pertussis, what is this? Infuriating, right? All right, so they have a coughing fit. They cough, 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 cough. They're not breathing while they cough. Then they have that, where they have that very sharp inhale. How do we treat this? Blow by oxygen. Try to keep the kid calm as possible. The more worked up they get, the more spasms they'll have, the more coughing fits they'll have. Guys, for these upper airway issues, what can we think about treating with? Humidified oxygen. Okay, this isn't particularly an upper airway issue, but try to cool and soothe that irritated tissue as best as we can. If you have them, use an OPA, NPA, the same on a pediatric as you would an adult, but only if they're pediatric size. Okay, do not shove a 36 diameter NPA down a 2-year-old's nose. Not good. Okay. Everybody good with what blow by is? That we probably will use this a lot on kids?
Yes.
Okay, thank you. That's another good effective method for blow by too. If you have a cup handy, you can kind of make a funnel system instead of just having it come from just the small opening of the tubing. So you can try to improvise with that. Guys, for the most part, you should have, I know at Grady we do, but most services carry pediatric size BDMs, nasal cannulas, non-rebreathers. The adjuncts, not as much, but you should have those. Guys, what's the one thing we need to know about shock in kids?
We have a shorter window of time.
They compensate, and then crash. Whereas adults will compensate, and then we have a nice gradual decline in that decompensated shock before we hit that irreversible stage. Kids will hang on and hang on and hang on, and then they are done. All right, so if we have poor findings on that PAT, or we get on scene and we're like, oh crap, this kid's sick, first question that needs to come out of our mouth after we formulate that in our head is, how long have they been this bad? If mom says, oh, they just got this bad, like I just called you guys 10, 15 minutes ago when it started, okay, we've got some time. But if the mom was like, I don't know, they started acting like this last night, I put them down to sleep, I figured it would get better, they just needed some rest, we are in a very high pucker factor territory. I need to re-explain what that means. Okay. Guys, they're gonna present the same way with shock, right? They will eventually become pale, cool, clammy, will have that increased respiratory efforts, scalp color of the skin will change, all of that stuff. They're going to present the same, but we need to understand that time frame is much different for kiddos. What's your dose for epi for anaphylaxis in kids? 0.15 wet milligrams. What's your concentration? 1 to 2,000 technically, remember, because the way it's packaged. Guys, go ahead and start learning AEIOU tips. Have we talked about this yet? No. All right, this is a good mnemonic for pediatrics and adults. I believe it's on your thingy, is it not? Yes, it's on one of your posters. These are different things you need to be doing a checklist in your head when you have an unconscious, unresponsive patient. Could it be this? Could it be that? Could it be this? Let me check for this. All right, so alcohol, epilepsy, electrolytes, insulin, opiates, uremia, trauma, temperature, infection, poisoning, shock, seizure, stroke. All right, all of those things can make a patient be unconscious, unresponsive, and there's different ways that we can check to see, hey, is this an endocrine issue? Let me check a sugar. Is this an electrolyte issue? Hey, are they extremely dehydrated? Type thing. We're going to start learning AEIOU tips. We'll go back over it, I believe, in module 6. How do we manage seizures in pediatric patients? Same. Protect their head. Try to slap a non-rebreather on them if they're actively like grand mal seizing, and then be even more aggressive on that airway and those oxygen levels once they hit that postictal stage. What's another common form of seizures in kids? Okay, febrile seizures. What happens here? A very sudden increase, a drastic sudden increase of body temp. All right. What do we need to ask a parent or a caregiver if we have a patient who A, has had a febrile seizure, or B, has a fever at all? Okay, so maybe see if we can get like a time frame of when it started, where it started at, where it's at now, type thing. What's something else I want to know? Huh? Maybe what were they doing? Symptoms. Have you given them anything for the fever? All right. Have you given them Tylenol? Have you given them ibuprofen? I will never forget how infuriated I was and just flabbergasted I was. We ran a 2 or 3 year old little boy who had a febrile seizure. We got on scene. It came out as unconscious. So we get there. Mom's in the parking lot. The kid's laying like limp on the trunk of the car. We get there and I'm like, oh, what's going on, right? We immediately start assessing ABCs. The kid's breathing, burning hot to the touch. Yeah, he's been sick. Laid him down for a nap. He's been hot. He hadn't been feeling good. I walked in and checked in on him on the nap, and he was like shaking and stuff. And then I couldn't really wake him up from his nap. So he could have a febrile seizure. His temp, we actually had the plastic thermometers at that time was like 104. And I was like, okay, well, have you done anything for his temperature? Yeah, I wiped him down with alcohol. Guys, that's a wives' tale. Okay, so the theory behind that is that the alcohol kind of opens the pores and allows the heat to escape through the pores. Right? I had to legitimately have an educational moment with that mom who thought that that was actually a thing. All right, so ask if they've given any medication, especially to the paramedic level, because you can give acetaminophen, you can give Tylenol for a pediatric fever. But yeah, we want to let the hospital know that, because if mom says, yeah, I just gave him Tylenol 30 minutes ago, they can't have that Tylenol for another 4 to 6 hours. So that's something we need to relay to the hospital so they don't re-up them on another dose.
She needs you like outside her house for this. Probably gonna put them on the trunk with her.
What is another common thing about pediatric seizures? Yeah, they might have different presentation with seizures. They might have the absent seizures, or they might have just that focal. Those are very common in pediatrics. Most of the time, it's the ticking of the eye. Like if they kind of zone out and their eyes are kind of bouncing. Right, that's a very common presentation in focal seizures for kids as well. How do we treat that? You don't really do anything? We just try to notate if it happens again en route type thing. Again, guys, meningitis is very not common, but it can be pretty bad for kiddos. Comes in viral and bacterial form. What are we going to see here? What is it? Are these kids going to be like, hey, mom, my neck really hurts? No, so maybe restricted mobility, irritability, tired, fever. You get to the point where they're having seizures. Photophobia, rash. My youngest actually had meningitis when he was 3 weeks old.
What's the
The photosensitivity, the light hurts their eyes. So not fun. So there's an example. This is on a geriatric patient, but there's an example of the rash. It's just kind of that almost kind of looks like a heat rash, but that might be present. That's why we need to strip these kids down if they're altered, anything like that, see if we notice anything else. What can you give kiddos for accidental ingestion? What's your dose rate? 1 to 2 grams per kilogram. How do you go from pounds to kilograms? Okay, so you can either take the pounds and divide it by a 2.2, or you can cut the pounds in half and then subtract the first digit of the number. So 40 pounds, cut it in half, that's 20. 20 minus 2, 18. So 18 kilograms. And then your dose for activated charcoal would be 18 to 36 grams. Again, guys, for GI issues, if they're vomiting, they can still be susceptible to appendicitis, anything like that. Same presentations, same management, still code 1. Okay. Definitely call poison control if it's an ingestion. Vomiting and diarrhea, guys, we can have hypovolemia very quickly in these kiddos. All right, less surface area, more fluids loss, the bigger effect it's going to have on these kiddos. Look for those signs and symptoms. Y'all can't do anything about it. That's poor turgor. All right, remember that tinting of the skin. If we can do an ALS rendezvous with this, if it's quicker than get them to the actual hospital, these kiddos are gonna need fluids like ASAP.
That's because they're a little dehydrated, right, or they are dehydrated.
Yes, significantly
So if they weren't
dehydrated.
dehydrated, they would stay closer to the head.
And it would just kind of pop right back.
Pop right back.
Again, drowning is common because they don't understand that full grasp of cause and effect. How are you gonna manage this? Same as an adult, right? CPR, prepare for a lot of suction because they're probably gonna be puking up the fluid that's in their lungs type thing. Talked about trauma. All right, so here's just an example of how little they have to lose when it comes to blood volume and fluid volume before they start to go into shock compared to adults. So again, if we've got a moderate amount of blood loss on scene, we're going to very much consider taking that patient's code 1. If we're not in that kind of decompensated stage yet, it's a matter of time before they get there quickly. So take that into consideration. Keep in mind the rule of 9s changes with kids and infants, right? Their head's significantly larger in value. Their limbs are shorter in value, or smaller in value, but go back and remember that. Module. Guys, just keep your head on a swivel for scene safety when it comes to suspected abuse. But what are some things that we might see that might make us say, let's take a step back. Let's look at this a little bit more clearly. Let's ask a couple more questions for abuse and neglect.
When you observe how the child interacts with that adult.
Okay, so that's a big one, right? If that caregiver is not a source of comfort, you're, as the stranger, a bigger source of comfort to that kid than their caregiver, that's something to think about. Now, there is, certain situations where parents just don't really bond or have that, connection with their kids. But more than likely, if they're hurt or if they don't feel good, they're going to want mama, daddy, like whoever's a sense of comfort to them. Old injury patterns or old injury markings, right? If the mom is saying, oh yeah, she just fell off the couch and fell onto the remote, so that's why she's got a bruise on her butt or on her leg, but then we assess that area and there's all sorts of green and yellow bruising and there's old scarring and all of that stuff. That didn't just happen. All right, what else? Huh?
Their appearance, they have the weight.
Okay, so maybe thinking towards neglect, right? Are they just emaciated looking, like they're not getting enough food? Are they just excessively dirty, like they're maybe not getting hygiene care from somebody else? Guys, especially if they're in diapers, if they're in a diaper that's been soiled for a very long time, like if there's feces like dried to the skin, or it's just like dragging the ground saturated with urine. It takes a while for that stuff to happen. Okay, overall living conditions, right? If it's something where there's no running water or there's just biohazard stuff everywhere, urine, feces on the floor, stuff like that, we need to get involved. What else?
If the injuries match the explanation.
Right, if the injury patterns match what the parent says happened. If we've got scalding burns from here down and nowhere else, but the parent says, oh, they grabbed a pot of hot water off the stove, or they grabbed my hot bowl of soup off the stove. Those splash patterns match. Because if an infant grabs something, because that happens, they're curious, right? They don't know that's hot boiling water. They can grab it off the stove, they can grab it off the counter. Where's that gonna go?
Everywhere.
Everywhere, right? A lot of parents will choose to have that scalding hot water and like dunk the kids in the water as punishment. So make sure injury patterns match the story. What else?
Parents' reaction,
Parents' reactions, like what?
like, if they're kind of downplaying an injury, or if they're super, like, extremely close to them, they don't want anyone to, like, really take a look at them.
Yeah, so guys, if parents are very, very hesitant, or caregivers or whoever that's involved with this call is very, no, you don't need to look at that, or no, you don't need to assess that, or very like absolutely refusing to leave that patient in any capacity, that can be a red flag because they don't want the kid to tell the truth about what happened while they're gone, or they don't want us to see those reoccurring injury patterns. But also keep in mind too, you can have those helicopter parents that are just very, you know, they hover over their kids because they care about their kids. So understand that that can be in place, but it doesn't always mean. Yeah, guys, if you're asking the kid something or they look like fearfully at the caregiver before they give you like permission to do something or answer a question, sometimes that's a cue you want to pick up on.
I imagine if that kid was really badly hurt and mom isn't really freaking out, that might be a sign.
Oh yeah, that's also another thing.
If mom's just trying to downplay it. My mom would not downplay anything with me.
Yeah. But yeah, just some things to pick up on. How do we manage this? So we need to report it, but how do we need to report it? And how does that need to happen? Very discreetly, right? What don't we want to do?
Going to jail.
Huh?
Like making it known to the parent that you suspect something, or.
Yeah, guys, you got to downplay it. You got to keep a poker face. You got to ask for the duration of that call while you're in front of that parent like you were none the wiser. You're totally oblivious. Why? So I don't want them to refuse care. I mean, I still can get somebody involved if that's the case.
Getting caught is the best way to get them to do it again.
Guys, if these scumbags are abusing their own children, all right, who's to say they won't fly off the handle and do it to them again on scene, or do it to you and your partner?
They might just decide no witnesses is an improvement over whatever.
Okay, so your scene safety and that kid's safety is your number one concern. You got to be a patient advocate. So we're just gonna be like, oh, hey, cool, how about them Braves? Like, make that parent just totally thinking of that we don't know anything going on. What do we need to do on the slide? Yeah.
Observations.
Well, maybe we could probably wait until we get to the hospital and just have that kind of to the side verbal report to the doctor or to the nurse that's taking care of the patient. Or if it's something like an imminent concern, we'll get in touch with supervision and say, hey, you need to get PD to meet us at the hospital. We don't want PD to come on scene, right? Because that's going to escalate ridiculously. But just say, hey, we need PD to meet us at the hospital. This is what's going on. Blah, blah, blah. We need some immediate intervention.
What if you see active abuse?
Oh, yeah, calling PD immediately to the scene.
Would it be appropriate to say to PD that suspect abuse, or because I know that's a no-no for documentation?
So that's okay for a verbal report, right? Remember to keep your documentation in your chart objective AF, right? Because you don't want this abuse case or this custody case to be thrown out the window because of your subjective charting, right? That's going to be something that off to the side, hey man, like this is what's going on for sure. I got this, this, and this. But don't put that in your chart. Okay. Guys, sexual abuse is another thing too. It's not fun to think about, but it happens. All right. Same characteristics, the interaction between this kid and the caregiver, who it might be. And guys, human trafficking, sex trafficking, it is ridiculously prevalent in Atlanta. Okay. Like one of the major hubs in the country for human trafficking. I'm sure you're very well versed with this.
Coming in from Central America with like 6 children.
Yeah.
And they had no idea where they were going.
Like chills just thinking about it. but Atlanta's a major epicenter for it because of the airport. Okay, so be very mindful. Don't get tunnel vision just focusing on this injury or whatever. You've got to be very perceptive to your surroundings, the interaction between the patient and whoever's, providing care or with them. So just be very mindful of that. SIDS, guys, what is SIDS? Sudden infant death syndrome. This just happens. All right. Patients who were born premature, patients who had a mom who did drugs or drank alcohol, they're more prone to it. But sometimes, typically within that 1 year frame, kids will go to sleep and they just don't wake up. Doesn't mean that it's abuse, doesn't mean that it's anything like that. But this can happen. Again, if it is a cardiac arrest, keep in mind that this is a possibility, but also be perceptive of the surroundings for the call, for the scene type thing, because it could be abuse that led to this. Okay. Death of a child, guys, I really, with every fiber of my being, hope you don't have to run this call. All right. Even if you don't have kids, it's an awful thing to experience. But if you do have kids and you're on this call, it will wreck you. All right. Please use common sense. Again, in that therapeutic communications chapter, don't say these things, especially what.
I know, I understand.
It's okay. You can have another one.
Oh.
I would be in jail if somebody said that to me. Guaranteed, no questions asked. All right. So yeah, just use common sense, guys. And there's a couple of things that are different about pediatric cardiac arrests than adults. Okay. Unless it is a very obvious burned beyond recognition, decomp, decapitation, something like that. Even if we notice dependent lividity, even if we notice rigor, if we notice some of those dependent or obvious signs of death, we're going to transport that patient if it's a kid. Okay, unless it is glaringly obvious to everyone involved on this scene that there is no getting this patient back, we're going to transport and we're going to work a kid. With those very few exceptions, you don't leave a dead kid on the scene. It's just a courtesy to the patient or to the parent. Now, you're still going to actively work this in the back of the truck, okay? Because we don't transport dead bodies to the ER. They literally, if we roll in and be like, yeah, we know this isn't a thing, we know it's not salvageable, but we just brought them to you anyway, you're going to actively work this call and work that kid. When you call in reports, say, hey, we're coming to you, X age kid, cardiac arrest, compressions are in progress, blah, blah, blah. Be advised, rigor is noted on scene, dependent lividity was noted on scene. These pediatric hospitals, they know what you're doing. They are not going to yell at you if you come in with a pediatric patient who's got dependent lividity and you're actually working the arrest. They understand and they appreciate going through these motions to give these parents closure. All right, so that's a lot different with adults. But if it's, we don't leave dead kids on scene unless it is just very, very concrete. We're not going to work this. Okay, so just a little thing that happens when it comes to pediatric patients versus adult in cardiac arrest. I love how we always end on such uplifting subject matter. All right. Questions, comments, concerns? Okay. Everybody good on Zoom?
Actually, I have a quick question.
Mhm.
Any minor, or so adolescents, even a kid who's being detained by police.
Yeah.
How does consent?
If they are in custody of PD, PD makes the decisions. Yeah.
I'm probably gonna send it to you at 5 a.m. this ER. Maybe it comes. Maybe it was just
Don't do drugs.
Oh, yeah, I got to meet the president of the United States.
Did you?
Yeah, it's also,
What an
I
honor.
didn't know he was a witch doctor too. It's pretty cool.
Yeah, I mean, guys, psych is not discriminate for age, right? You have pediatric kids who have some significant psych issues, drug issues, not giving a crap issues. But yeah, you'll treat those patients, handle that scene safety, their safety the same way you would if it were an adult. But yeah, if any patient you have is in custody of PD makes that decision whether or not, okay, they're fine, you can just take them to Grady, or no, they're in custody. We can medically, like, if we think that kid or patient needs to be checked out, we can say, no, dude, I think you really, like, we need to check them out. They need to go to the hospital, and they'll just follow if they're still in custody. Okay.